Welcome, welcome, everybody. Happy Friday. We're excited to see you all for yet another RLR. This is an all-family affair led, of course, by Vinny, who is scribing. Vinny, I'll have you unmute. Tell us where you are and what you're up to today.
Hi everybody, I'm Beanie. I just came from wards. I'm in the 30 years, so rotating in pediatrics right now. And yeah, I'm very excited for today's case.
Amazing. You're always working and somehow still at VMR at the same time. Someday I will understand how you're able to juggle so much, but we're very, very excited to have you. Returning to the teaching point stage, I feel like I'm announcing a boxing match or something. Is our beloved Anmol, who is under the weather but still here. Anmol, where are you now? Give us an update.
Thank you so much. Hello, everyone. My name is Anmol Preet, and I'm currently in India and looking forward to the case today. I'm very, very excited. Thank you.
Anmol, we're so excited to have you back. Congrats on powering through many hard months of away rotations and being back home. Speaking of home, I get to introduce the case presenter who I share a home and a fridge with. And for those of you who are wondering why I said that, you should join the academy to find out the intimate details. But Kara, I'll pass the mic to you. Tell us where you are and how far you are from me, and what you're up to today.
I am in the adjacent room because Rebbe needs his space and to falsely claim that all of the plants behind him are his.
If you water them once, they become yours for life, even if you have never watered them again. Correct? No? Well, Prof. Rez, you should say hello, and then I think we will follow the order outlined by
Well,
Dr.
I want an announcement. Coming in at 6 feet tall, 200 pounds, pure muscle, known colloquially as Prof Rez.
Prof. Rez, I can't believe you're 6 feet tall. To me, you're like 7.5 feet, honestly, and probably to most people who see you in real life.
What's so funny is to me, you're 5'8".
Oy, oy, oy. Well, Prof. Les, good thing you're larger than life, and so no amount of number will ever capture the magic of Prof. Rez. I'm excited to also see that another Dr. Lau, not Dr. Lau, another relative of Dr. Lau's is also here. But anyway, Vinny, whenever you're ready, you can share the screen and Sarah, take it away.
Amazing. Okay, so I wanted to do this as though we were seeing the patient in real time. And so we're going to start in the triage room. Dr. Jaha, you have a person that comes in, 48-year-old woman, and she's not been feeling well, kind of malaise for the last 2 weeks with intractable nausea and vomiting for the last 2 days. A little bit more HPI because you're meeting her for the first time. She started having some nausea about 2 weeks ago that seemed mild, not much of a problem. And then 2 days ago, started having recurrent nausea and vomiting. She's continued to take her meds, but came to the hospital for like worsening symptoms last night. Vital signs in the triage room, her blood pressure is 118/54. Her heart rate is 89. She has a temp of 36.9 degrees Celsius, a respiratory rate of 19, and an O2 sat of 99% on room air. And obviously, Rebbe, I'd love you to start because you work in the triage room, but Reza, feel free to chime in when Rebbe misses something.
Not if, when. Okay, all right. So the triage room is yeah, to talk about the triage room. The triage room is a very important place for all of us to practice because it's really critical to make sure that you send the patient the right way. And I think it's so important to start to practice the skill out loud because I think most of us, whenever we're taking care of patients, be it in clinic or in the hospital, medicine has enveloped our patient. So what do I mean by that? Especially for those of you who worked in the hospital, most of the time you're encountering a patient who's been swallowed by us. And what do I mean by that? They're in a gown, they're in an IV, and they're essentially removed from their environment. So you will never get to see how they walked in, what they were wearing, how well kept they were, who came with them, how they got there. And all those things are really important. So just to add the layers of detail about what we don't have in this case, but what is really, really important to gather in real life, is if this patient walked in with nausea and vomiting, how different would that be than if she had actually called an ambulance? Because the ability to be able to walk and get to the hospital physically by yourself while being nauseous and vomiting is a profoundly important variable, in stark contrast to somebody who renders themselves unable to even make it into their car or mode of transportation. So that's the kind of thing you want to track in the triage room, is in addition to the medicine, which we'll talk about, is to understand before the patient is swallowed into the medical world, put in a gown, get in IVs, how did they actually come to your attention? So that's really, I think, profoundly informative here. The next thing that happens is that we take a glance at the triage vital signs, and thankfully the patient doesn't seem to have any sinister consequences of this syndrome, in that the heart rate is normal, the blood pressure is normal, though soft, and the O2 sat and the respiratory rate are normal. And so the question becomes, well, how do we begin to make progress on what she's describing? And there are two threads to that. The first is 2 weeks of a non-specific but systemic syndrome in malaise, and then maybe a little bit more specific syndrome in the nausea and the vomiting. And I'll just keep it brief, and then I pass the mic to Prof. Rez to reflect on the nausea and vomiting, because that's the thing that I would be focused on right now in the triage room. Nausea and vomiting in most circumstances reflects the vagus nerve being activated in a very specific location. I got appendicitis, so my right lower quadrant hurts. That triggers my vagus nerve and I get nauseous or vomiting. I fracture my ankle and I roll it. It hurts. My vagus nerve is triggered and I get nauseous or vomiting. Most of the time, when nausea and vomiting is present, you will look and you will see that there is a localizing clue as to where the vagus nerve is activated. Headache, nausea, and vomiting. Chest pain, nausea, and vomiting. Abdominal pain, nausea, and vomiting. What happens to the calculus when there is no clear sense from initially talking to the patient about where that vagus nerve is being triggered from? What happens? You realize that morbidity pushes you to make sure that it's not being activated in the head or the chest by an intracranial catastrophe or a cardiac one. And so you'll look closer and closer and closer for things of that nature, including a neuroexam and an EKG, no matter what. The most common location where you will not have accompanying symptoms and yet there is focality in the triggering of nausea and vomiting is in the upper gastrointestinal tract. That's because the upper gastrointestinal tract really doesn't do much beyond vomit when it's diseased. Pain would involve a transmural process, which makes the patient much sicker. So focal diseases that can present with pseudo diffuse nausea and vomiting are brain, heart, and upper GI tract. If you are unable to find a focus in those three categories, then odds are the reason you cannot localize the nausea and vomiting is it's because it's mediated by a molecular issue, either a deficiency in a substance, sometimes as crucial as cortisol in the form of adrenal insufficiency, or an excess of a certain substance like beta-HCG in pregnancy or cannabinoid hyperemesis syndrome. So when I hear nausea and vomiting, I fish for a localizing source. And if I don't find one, I make sure I do a good neuroexam and EKG, and I entertain upper gastrointestinal diseases. But odds are, especially in the face of a systemic syndrome preceding the nausea and vomiting, that you are looking for a molecule, whether it's something the patient is taking, like cannabinoid hyperemesis syndrome, or making, like beta-HCG. And so that's what I would be thinking thus far. Prof. Rez, anything else that caught your eye?
I think that's such an epic start, and nothing else caught my eye. I love Kara's nausea and vomiting thought train, and I thought you did a phenomenal job of highlighting that. Very a robust start to the case, Kara.
Okay, so you go back while she's, getting gowned up and being sent to a room. You go back and look at her medical history. She was diagnosed with diabetes, unclear what type, at 21 years old, and has been on insulin since. She has been compliant with all of her medications. She, mainly caretakes for her family at home, doesn't work. And she, on review of systems, really doesn't have like a prodrome besides the nausea and vomiting. No abdominal pain, no like fevers or chills, no recent travel, no sick contacts, no shortness of breath or chest pain. She, let's see, her home insulin regimen is Lantus 24 units at home plus Prandial that she adjusts based on what she eats. And she started atorvastatin 3 months ago. She hasn't really been able to eat much or drink much because of the nausea and vomiting in the last 48 hours. And then I apologize, Vinny, but I'm going to give you a lot of information. So you get preliminary labs because you sent those off while she was being kind of set up in, we'll say, the acute side. Her CBC is largely unremarkable. She has a white count of 7, a hemoglobin of 16.1, platelets of 182. Her BNP is as follows. She has a sodium of 137, a potassium of 3.3, chloride of 112, CO2 of 5, an anion gap of 20, a glucose at 261. BUN is 28, creatinine is 2. Divalents are normal. Her AST is 402. Her ALT is 730. Her ALK phos is 637. Her bilirubin is 1.9. Lipase 363. Trop negative. A1C 10.3. She has a UA with 1,000 greater than 1,000 glucose, greater than 80 ketones, negative for any cells, esterase or nitrites. A VBG of 7.14, 27.3. A lactate of 2.9, and a beta hydroxybutyrate of 0.48.
Are we ready for the magic, Prof. Red?
Oh, perfect. A lot of data here. And yeah, and I was just watching as you were also talking, Kara, one of our cats for the first time jump at the edge of the window, which I'm very proud of.
Wait,
as a
who
cat
did?
dad.
Who is it?
Yeah, let me show you. This is Sydney.
Oh my God, Sydney's jumping? Wow.
Yeah, Sydney is jumping. But back to the case, and it's so interesting. We had that one abnormality in Red Robbie, which was the respiratory rate. But you didn't comment on it. I didn't comment on it because, quite frankly, unless the respiratory rate is like 24 or greater, it's hard to really know, did someone actually count the respiration? But now this case has taken quite a turn, and this patient is very, very, very sick. And I'll share my general thoughts and then would love for you to layer on those thoughts because there's so much data here. And when you have so much data and so many signals, I think it's really helpful to put one signal as the center of your discussion. And if I asked you in the audience, like, what would that one laboratory data or symptom be? It would, of course, be the bicarb. This is going to be a bit tricky, and I'll explain why momentarily. But whenever you have a low bicarb, remember, when you're interpreting acid-base disorders, you need a VBG and you need the Chem7. The BBG uses the Henderson-Hasselbalch equation to calculate the bicarb, while the Chem7 actually measures the bicarb. There's only one acid-base disorder that you can diagnose on a BMP, and that's an anion gap acidosis because the body never compensates for an alkalosis by creating an anion gap acidosis. And so when the bicarb is 5, you can truly believe that there is going to be an acidosis, but it's typically when it's like 18 where people mistakenly say, oh, there's an acidosis. No, you don't know if there's an acidosis. We actually had a case in Morning Report recently, and it was really the patient had respiratory alkalosis and then compensatory, drop in the bicarb. But once you label an abnormality, it's not enough to stop there. You got to ask, like, what's driving that abnormality? So let's go through the acid-base disorder here. And I'm just looking for the VBG, which is right there. And Carrie, can you remind me what the PCO2 was?
23.
23. Thank you. So right away, the pH is low. So we know we're dealing with acidosis. The PCO2 is low, which is what you would expect when the pH is low to try to compensate. So we know we're dealing with a metabolic acidosis. And we have an anion gap. So we know we have an anion gap metabolic acidosis. You don't need to memorize mud piles. It's so confusing. Just think of 4 simple buckets: renal insufficiency, ketones, lactate, and then a toxin or medication. And you don't want to just focus on one of these being positive because you might miss another cause that's positive. So right away, Kara was kind enough to tell us that the beta hydroxybutyrate was positive. She has a history of diabetes. She's insulin dependent. We know that this person is in DKA, has a component of ketosis, And you can also see that her glucose, I imagine, is elevated. I'm just trying to find that number here on the whiteboard. But the UA is also showing a lot of glucose. So you've passed the threshold of the proximal tubule for retaining that glucose. So we know we have ketones contributing to her acidosis. And I'm looking for her creatinine too. So there could be a component of renal insufficiency. And quite frankly, she may even have a lactate that's elevated that I would measure. So she could have multiple stuff contributing to this anion gap metabolic acidosis. Then the question becomes, how do you go beyond that? So does she have a non-gap or normal gap metabolic acidosis? It's very simple. Don't make it too complicated. Take what the expected anion gap is, and you have to be cautious of the patient's albumin, but usually we use 12. Subtract it from the 5 that the patient has, and you're left with 7. Take that 7, add it to the 5, and you're 12. So this patient also has a normal gap metabolic acidosis. So has an anion gap metabolic acidosis, has a normal gap metabolic acidosis. And then if you want to know if there's a respiratory process involved too, you just use Winner's formula. And that's 1.5 times the bicarb plus 8 plus minus 2. So if you take 1.5 times that bicarb, it's around 7.5 plus 8, you're around 15. And her PCO2 is 23. So there's a component of, I would say, respiratory acidosis here. So you have a triple acid-base disorder, anion gap, probably from ketones, renal insufficiency, maybe lactate, normal gap metabolic acidosis. She wasn't really giving us any history of diarrhea, but she's been vomiting a lot, and she probably has a renin-angiotensin-aldosterone system activated. And you have a respiratory acidosis. And the respiratory acidosis, quite frankly, when someone becomes so acidemic, they start having problems with their breathing. So this is a patient I'm very, very concerned about. And I know I'm talking a lot about the acid-base disorder, but it's really important because at any moment, if this patient's respiratory drive just gives up an ounce, she will be dead. She'll have a sudden cardiac event. So this is a patient that has to be in the ICU, speaking of triage. But whenever someone has, like, you're worried about DKA, like, it's because she's insulinopenic. But why is she insulinopenic? She might not be using her insulin, but why isn't she using her insulin? She has nausea and vomiting. Sometimes when people feel crummy, they don't like taking their insulin. They're not educated that you always need some long-acting insulin on board, or there are serious ramifications. And this is where it gets tricky. It gets tricky in that, could she have a trigger for DKA? And that's what we're dealing with here. I don't think that's the case. She's had this sort of subacute illness. I think more likely there's something else in the background, and now she isn't taking her insulin, and now we're seeing the ramifications of all this stuff right here. And think about it, like how many patients have you had with DKA that have these abnormal liver chemistry tests? And since I've talked for so long, I'd like to pass the mic to Robbie to take it further and incorporate the rest of that data. But Robbie, like honestly, I'm just really concerned about the patient. They need ICU level of care. I think the story is more than just, oh, this is someone that has DKA because something is triggering it. I think there's something in the background that caused this patient not to, and we had to figure out what was that in the background that led to these sequence of events.
Prof. Rez, I know that some of your beloved family members always wanted you to be a cardiologist, but I think you were born to be a nephrologist, honestly. From the very moments that Prof. Rez and I started to do CP solvers, you can just tell that his love for pathophysiology, physiology specifically, and then whenever it's anything related to like acid base or kidney, it's just nobody, in my opinion, teaches it even close to how well you did. That was amazing. And I am right there with you. I think the liver enzymes are the like plot twists that are not part of the narrative, and I think they're worth analyzing. And I think the simplest way to analyze these liver enzyme abnormalities is actually just to start with the alk phos. The alkaline phosphatase has tremendous localizing value in this instance because you're not worried about any bony localizations of alk phos based on the fact that the patient doesn't have any pain and the other liver enzymes are elevated. And so what you really have to do is to say this alk phos tells me there's some bile duct injury going on. And the question that whenever we have an elevated alk phos that's of the hepatic in origin is we know that the bile ducts are existing in the extrahepatic biliary tree going from the liver all the way down to the duodenum. But they also infiltrate the liver and spread microscopically throughout the liver. So if you were to retrace the journey of bile, it starts off in the actual microscopic biliary ducts in the liver, and then it collects together in bigger and bigger and bigger and bigger bile ducts, and eventually enough that the radiologist can see them on the imaging modalities we use. So we know that this patient has some injury to some bile duct somewhere. And the thing that we try to do is we try to say, well, is it actually in the microscopic bile ducts in the liver parenchyma? Or is it in the macroscopically visible bile ducts that course outside the liver parenchyma and connect into the pancreas and then ultimately dump in the duodenum? And the way we do that is by imaging. But the clues we can accumulate before imaging give us a pretest probability of what the imaging might show. How much AST and ALT is located in the extrahepatic biliary tree? 0. None. How much lipase is located in the liver? 0. None. This patient's AST and ALT suggest that the alk phos is coming from the liver itself, but the lipase suggests a disease involving the extrahepatic biliary tree. Life, my friends, is all about who and what you trust, because you're going to get false signals all the time. And what do we trust here? Do we trust the AST and the ALT, or do we trust the lipase? And both of them have situations where they can become falsely positive. Here, I'm leaning to trust the AST and ALT more because this patient does not have epigastric pain to suggest involvement of the pancreas, but I don't know. This could certainly be extrahepatic biliary disease, with the lipase being the clue, or intrahepatic. And so what would I do in real life? I would explore both threads and say, okay, you know what? Could this patient have acute pancreatitis? Very much so. What are the 3 common causes of acute pancreatitis? Alcohol, not relevant here. Gallstones, very relevant in a patient with diabetes, much higher risk of gallstones. Wait, gallstones can cause acute pancreatitis, and they are the only cause of extrahepatic disease resulting in acute AST and ALT elevation, because the stone lodges in the distal bile duct and transmits its pressure so abruptly and so acutely to the actual liver itself, resulting in popping of AST and ALT. So could this patient have simultaneous intra and extrahepatic biliary disease from the mechanical obstructive effects of a gallstone in the common bile duct and the pressure transmitted into the liver cells, causing burst of AST and ALT? Very possible. What's the last common cause that's worth entertaining is hypertriglyceridemia, especially in a patient with uncontrolled diabetes. And so I think that's the thread that the liver enzymes, the question is, where is the problem? Inside or outside, or is it both? And is this patient have pancreatitis, or is this lipase a false positive, as it can happen in patients with mild kidney injury? And so I think looking at the biliary tree is going to be important. Sending off a triglyceride may be something to consider here. But I agree with Prof. Rez. I think we have to analyze the DKA as a consequence of whatever else is going on, not the cause of the entire picture. All right, Kara, back to you.
Oh, I wish I had you guys with me when I was admitting overnight. Reza, this next aliquot is for you.
You know what I'm picturing right now, Kara? Like, I'm on your right shoulder, Robbie's on your left shoulder. But I'm telling you the wrong stuff. I'm like the devil, he's the angel telling you the right stuff.
I think both of you have pitchforks. Reza, you are the admitting overnight night hospitalist, and you receive a page that a patient is being admitted as a transfer from an outside hospital with liver enzymes in the thousands. And your liver transplant team has declined initial admission for transplant evaluation, but she's come to your hospital for a higher level of care and subspecialty consultation. You get that packet that has all of the information that Rabih just had, and some initial workup that the ED has done. Again, sorry, Vinny, a lot of data, but her vitals are 160, her blood pressure is 163/91, her pulse is 119, her respiratory rate is 20, her O2 sat is 95% on room air. She, on first glance, like you kind of walk by to evaluate her, she's not in any acute distress, and she's actually not that ill appearing. She's alert and oriented ×4. She has no focal, like nothing that's focal on her neuro exam. She doesn't have any asterixis. She does have icteric sclera. She's, when you listen to her, she's probably in regular rate, no murmurs. She has +2 edema in her bilateral lower extremities. Her lungs are clear. She's on room air. She's got a protuberant abdomen. It's distended, it's soft, it's non-tender, but it's kind of dull to percussion. Maybe you can get a fluid wave. She had some dark urine in a Foley bag. Otherwise, she has warm and dry skin. And then her labs, the main things you note are that her creatinine is 5.53. Her lactate is 1.1. Her platelet count is 82. Her INR is 1.7. She has a troponin of 0.41, an AST and an ALT greater than 1,600, both, an alk-phos in the 800s, a lipase of 7,236, and a ferritin of 32,154. In your packet, there's an MR abdomen with and without contrast that was done that just note moderate ascites and small bilateral pleural effusions, no evidence of biliary obstruction or cholecystitis. The rest of the detailed findings are negative. And an ultrasound of the abdomen report that says a possible hemangioma in the right hepatic lobe that was similar to one seen in a previous study in 2022. Sorry, yeah, 2022. And bilateral non-obstructive nephrolithiasis, but the spleen and gallbladder appear unremarkable. And that's the end of the second aliquot. Third aliquot?
Wow. And then Kara, as far as like the timeline, so is this is the same patient, or is this the same patient? And the initial labs was from Rabih's hospital, and now the patient's being transferred to my hospital. Finally, the patient's gonna get some good care. Yes. And did the ultrasound show ascites?
Small.
Well, okay. Well, I say that in jest because Rabih, I will definitely need your help because I love this case so much. It's such an important case. Like, I think we've been striving to bring more practical, fundamental cases to VMR. And this is why I love it, because I neglected to make a very important teaching point when we were worried about DKA. And that is, when you treat DKA, it's really 3 pillars. And the first pillar is fluid. The second pillar is potassium. And the third, yes, the third pillar is insulin. And if you look at this patient's potassium and you rush to give them insulin, you may kill the patient. I know I'm being quite morbid on today's VMR, but it is true, right? Like, you gotta, and just simplify. Remember though, those are very important teaching points for DKA. Now we have another striking, labs from this patient, and we're going to do the same exercise. What is grabbing my attention and what needs to be explained? It's a liver chemistry test. Like, you have AST and ALT in the thousands. And, you have to pause just for a second and make sure you're not dealing with skeletal muscle issues. Like, this has happened before. But I think here we have a lot of signal that no, this is liver and this is not extrahepatic. And when you have AST and ALT that high, you have to think about 4 causes off the bat. And I would say a very common etiology is acute hypotension or ischemia of the liver. That's actually much more specific than just hypotension. Like, you can have normal blood pressure, but have ischemia of the liver. We even had an RLR case of where the portal vein was completely thrombosed and we had ischemic infarct to the liver. So ischemia. Another common culprit is viruses, specifically the hepatitis viruses, though even herpes viruses can cause this robust increase in AST and ALT. Thirdly, you got to think about toxins. Like, such a low threshold, like, she wasn't feeling well. Was she taking a lot of Tylenol to start N-acetylcysteine? So Tylenol, known toxin, and there's other toxins, but there's a long list. And then there's a 4th cause, which I didn't appreciate until Tony Brew tweeted or published the case, or Andrew Olson, which is stones. Back to what Rabih was saying, how interesting a stone might be able to explain both phenotypes. And that reminds me of another very important pearl, which is the diabetes. So all of a sudden, like, maybe she doesn't have pain because she has neuropathy. Like, all of a sudden the history isn't as telling as one would expect it to be. That's a really important point. So I have hyperbilirubinemia. Even if I don't have abdominal pain, I still have to consider cholangitis and look for other markers of inflammation. There was no evidence of ischemia that was reported to us. We still have to explore the stone hypothesis, though we have an ultrasound. It doesn't definitively rule out a stone that has left and went into the biliary tract. You really need an MRCP. We do have an MRI, but again, an MRCP is the most specific for the biliary system. And then toxins are always difficult. You got to ask them, like, and toxins can impact the liver and they can impact the pancreas. And the pancreas is another, like, that lipase being that high, she has pancreatitis, like, even without abdominal pain, like, that pancreas is extremely inflamed. And so again, like, using base rate, we would prioritize stone, but we already have some data that's pushing us away from stone, be it the ultrasound, be it the MRI. And then I think next on that would be a toxin or a virus, something that might be attacking both the liver and the pancreas. Then you have to do one more thing. When you have AST and ALT this high, this is severe acute liver injury, and you have to ask yourself, is this liver failure? And that's why Kara told us that there was no encephalopathy, there is no asterixis, and therefore, and you can get an INR too, but it's elevated, it's 1.7, but we don't know if that's because she's vitamin K deficient. So she does not have acute liver failure, but she does have severe acute liver injury. And already, Kara, as that night hospitalist, I am thinking that probably the safest place is going to be minimum step down, but likely ICU, because she can at any moment develop acute liver failure. And remember, this is a patient who had no liver issues whatsoever. So it's not decompensation of a chronic process, but rather a new acute process, which means the treatment algorithm may eventually involve transplant. So I would put her in the ICU. I would get hepatology on board. But with that very high ferritin, it's really hard not to think about hemophagocytic lymphohistiocytosis. And then you quickly look at her complete blood count, but she doesn't really meet those criteria. And then you're reminded that any inflammatory process can cause a very high ferritin level. But it's good to just run that that possibility by looking at the cytopenias. So I'll just summarize because there's so much information here that we have a patient who has a history of diabetes, unclear what type, who's been on insulin, has recently started atorvastatin, and now is presenting with nausea and vomiting for the last 2 weeks that has acutely worsened, with laboratory data showing severe acute liver injury, severe pancreatitis, and DKA. The DKA is a consequence of everything that's happening. We need to understand what's happening to the liver, what's happening to the pancreas. She does feel completely normal and she looks normal, which is interesting, but we have to be cautious because she does have diabetes. But of all those causes we listed, usually toxins are the ones that are silent in their damage to the liver. Passing the mic to Robbie, but I can't pass it without saying one last thought. Robbie, please don't come over to LA and slap me. Is that because the fundamentals, when you have ascites, you got to tap it and you got to ask 2 questions. Is there SBP? Is there portal hypertension? Mike, to you, my friend.
What a great alley-oop, Prof. Rez, because I really think that that's the part that I'm finding so much friction with. And just to start off, like I think that like the framing of this case is acute liver injury and the prioritization of all the causes that you mentioned, but the sneaky ones is the toxins is such a great place to anchor us in. And so part of what clinical medicine is so much about is like take what you have and make progress, as you heard Prof. Rez do, but then acknowledge the friction points. And so let me try to explain to you why I am getting stuck with the ascites. Whenever you have a patient with any kind of organ disease, you want to localize the time course because as Aaron tells us, the disease is all about localization and time course. So in general, if you have to really remove yourself from this case to have this conversation. But so in general, whenever you're faced with trying to figure out what the patient's tempo of their liver disease is, you often use clues about the liver enzyme elevations and the presence of portal hypertension to make progress. So in somebody with acute liver injury, they often have marked elevations in their liver enzyme elevations, but they have no evidence of portal hypertension. That's because in order to get portal hypertension, you need the chronic fibrotic state of cirrhosis to kick in for the pressure to be transmitted to the portal vein enough that it leaks. So here, the presence of ascites, presumably without any other reason than portal hypertension, is a very interesting plot twist. Could this patient have had chronic unrecognized liver disease and now be manifesting in an acute way? That's very possible, but here's the strong counter argument against that. If you have significant enough chronic liver disease for so long, you rarely are able to release this much AST and ALT into the system. It's why you will almost never see a patient with chronic dialysis mount a creatinine of 15, 16, or 17. You may see a creatinine 15 to 16, 17 in somebody with acute kidney disease because they have so much muscle mass left to give that creatinine, but you're never going to see it in a patient with dialysis for 5 years, no matter how bad their kidneys get. Same is true for liver disease. So, gosh, this case is all about tension. In the initial aliquots, the tension was, is it the lipase or the AST-ALT? In this aliquot, is this acute liver disease with portal hypertension? Or is this chronic liver disease with crazy numbers, AST-ALT? And I think here, it's a question of trust yet again. What do you trust? There are a subset of acute liver diseases that present with disproportional portal hypertension. And the most important ones are Budd-Chiari and acute decompensated right-sided heart failure. So I'm looking at this case and I'm thinking, oh wait, she's diabetes. Her troponin is positive. She's tachycardic. She's not hypotensive, but I would be really, really anxious to make sure the BNP is low. And I would not be surprised if her BNP is high. And that would make me really, really worry. So I think I have, I think I have some angst to make sure that this liver status is not part of a hemodynamic picture that it's causing the liver to burst, the kidneys to go offline, the pancreas to go offline, and what else? Yeah. So I think that sampling this fluid is going to be very, very important. I think the progress we can make with simple tests, I'm trying to think of what are the simple tests that you might get, are a BNP, a TSH and a free T4, and a triglyceride level. Yeah, the paradox is really of acute liver disease with portal hypertension. It's a tricky one to try to make progress on. All righty, Carol, what do you have next? I'm kind of scared to hear what you have next.
I know. I was pretty scared too. She was in the TCU and I was taking care of her. Basically, she's on an insulin drip when she comes. She gets a stat echo overnight that there is like no evidence of like ventricular dysfunction. Her BNP is in the low 100s. Interestingly, her IVC was small. I don't really know what to make of that. She had let me see, her ascites was tapped. It was not exudative, and there wasn't evidence of SBP. And she seemed stable enough. I put her, I continued her insulin drip. But despite, continuing on the insulin drip into the next morning, the patient's anion gap didn't close, and all of her repeat electrolyte panels and liver tests were still like mirroring what we had seen when she had been transferred. There seemed to be a slight improvement in her beta hydroxybutyrate. It had initially increased to 0.88 and then came back down to 0.44 while she was getting treatment for presumed DKA. Her repeat VBGs were all on the order of a pH of 7.22, a PCO2 of 37, around that area. And by the next morning, her creatinine is 6.84. Her bicarb is still 11. Her anion gap is 18. She is anuric. She has a serum osmolality of 302, a negative salicylate, negative Utox. She denies any ingestions. She has been getting IV fluids with the DKA treatment, and it hasn't really improved. In fact, it's just made her more volume overloaded appearing. And yes, her LFTs remain in the 1600 range.
Carol, one quick question. Do you know how many aliquots we have left just to manage the rambling?
I know time. There's one more, which includes a lot of liver tests, but
okay, all right, sounds good. Professors, I feel like I babbled a lot. So maybe I can just reflect on the TAP and then pass the mic to you to reflect on the insulin and whatnot. And I think the TAMPA is really helpful because by Kara saying there's no exudate, we can assume to mean that's a transudate, which means that the patient has portal hypertension. And so if we ask ourselves, where is the portal hypertension originating? Is it post-hepatic, intrahepatic, or prehepatic? I think we can now, with the BNP and the echo, say that it's not post-hepatic and it likely is intra or prehepatic. And when we have such significant intrahepatic evidence with high AST, ALT, I think this is now a question of the patient having both acute liver injury and intrahepatic portal hypertension. And of course, I think it would not be hard to say, okay, maybe any cause of acute liver injury this bad can cause so much swelling that the portal venues get blocked and the patient gets portal hypertension. But now I think it's probably fair to say, okay, in addition to that non-specific hypothesis, is there something infiltrating the liver in a manner that's this aggressive? And so I'm starting to think of, okay, is the liver taken over by something? And I don't think that there's any actionable steps generated from that quite yet. But I was starting to look at the imaging to be like, wait, how confident are we that that is a hemangioma that was noted and not an infiltrative lymphoma or sarcoma or some acute devastating process like that? My mind also, I remembered also something that Sammy Maddie taught me about a condition called glycogenic hepatopathy, where in patients with really bad uncontrolled diabetes, especially type 1 diabetes, they have a lot of glycogen infiltrating their liver. I've never imagined that, or I didn't read enough about it, and I've never imagined that to be this severe. I always thought it was actually mild to moderate liver injury. So I'd be trying to review to see if there have been case reports described of it being this bad. So I think from a fluid perspective, we have portal hypertension. It's not post-hepatic, it's likely intrahepatic. And the question is this just a non-specific manifestation of the severe edema of any process causing this bad of a liver injury, or does it open the door to say there's something taking up space in the liver, malignant granulomatous or intracellular like glycogen? Prof. Rez, under your excellent care, this patient's insulin gap is not closing. What are you doing?
Can I be honest? Like, I'm very puzzled, Kara. Like, my mind, like, I really don't know. I thought Robbie's point of making sure not the heart was a very good point, because I've been burned on that before, in real life. I think, the question is like, there's so much signal in each of these, or it's basically multi-organ failure. You have the kidney that's out, the liver that is going out. You have evidence that the heart is okay, but there's a troponin leak from there too. For just 1 second, I want to just talk about the anion gap, because that's something else that we were mentioning. It's important that at time point 0, we all thought this is going to be ketones. We all thought in fact, with fluid, the kidney injury NDKA gets better. It gets better because it's an hypovolemia from an glucose-induced osmotic diuresis. So the fact that it isn't getting better, again, makes you question whether all this is, and it isn't. It isn't all driven by DKA. But the persistent anion gap not only makes me think of the renal insufficiency this patient has, and now they can eliminate phosphates and sulfates, and that's why they may have a persistent anion gap. And it's just a surrogate of what's happening to the kidneys. And so the real question is, what's happening to the kidneys? Though there's, one toxin that we have to really consider here, and that's Tylenol, because we talked about this. Tylenol can cause severe acute liver injury. Tylenol can cause pyroglutamate acidosis in someone who's malnourished and has a weak acting liver and a weak acting kidney. So I would, that's something to really consider strongly. I would probably give this patient N-acetylcysteine. Honestly, I don't know what the drawbacks are of that. Yeah, Robbie, I think I would calculate a serum osmolol gap and see if there's like a toxin that might be on board. But like thinking of methanol and ethylene glycol and isopropyl alcohol, I can't really think of those as causing this picture. And honestly, with a lot of these toxins, initially the patient has like a totally normal gap, and it's when the toxin gets broken down that the anion gap increases significantly. But in any case, I would be worried about toxins. And then the kidney, like, it's just so hard to imagine that this is all pre-renal. Remember, we're not dealing with a patient with cirrhosis. Like, there isn't evidence of cirrhosis on imaging, on etc. So, like, that's because you might be thinking about hepatorenal syndrome, but that's really in the context of cirrhosis and splanchnic vasodilation. But I'm just thinking, like, what intrarenal cause of AKI can we be missing? It's not post-renal. I mean, pre-renal shouldn't do all this, and you're giving them volume. So then you're left with, is there something happening at the glomerulus, the interstitium, or the tubules? Could there be ATN? Of course there can be. Could there be something obstructing the tubules that's also infiltrating the liver, like a plasma cell dyscrasia? I have no clue. But right now, what I'm thinking is, how do I get to an answer? Yeah, we're gonna send all the liver stuff, like all the hepatitis viruses, probably send the autoimmune hepatitis stuff, because we don't know if she has type 1 diabetes. You'll probably send, hemochromatosis, Wilson's, all that stuff. But I'm thinking, like, does she need a biopsy to get to an answer? And now that she's anuric, she needs dialysis. She's only 48. We gotta work hard to get to an answer. But I don't know what that answer is. And I'm really interested in learning from you and Kara what the next steps should be.
Great. I felt very, very similarly and a lot of concern with the tension. She, like, vitals wise and exam wise, was very stable. And so we got a lot of consults and decided to give her some time. So renal was consulted with concern for renal failure. Her UA had muddy brown casts when they spun it. And so she was initiated on dialysis, given she was getting more volume overloaded, with concern for ATN. Hematology was consulted regarding the elevated ferritin, concern for HLH type picture, but they weren't initially that concerned looking over her studies. They wondered about hemochromatosis, but knew that we were sending that with a lot of the liver workup, which I'll tell you about in a second. And so we're just kind of following along. Hepatology was on board from the beginning. And so they initially recommended a lot of the liver workup, which I'm about to tell you. But in the meantime, while all of that was coming back, while on dialysis, endocrine was consulted to just really discuss the contribution of DKA to her overarching picture. And they were actually not that concerned that DKA was contributing a whole lot to her acid-base status, because her beta hydroxybutyrate rate was very low to normal. And so they actually took her off the insulin drip and transitioned her to sub-Q, and recommended that we really investigate other causes of her anion gap and gap metabolic acidosis. And so as the liver injury workup was coming back, she actually started to improve. Her LFTs began to decline a couple of days into dialysis. And she had negative hepatitis panel, negative HIV, negative EBV and CMV PCRs, negative adenovirus. She had negative autoimmune workup. Her SIL2 RA level was elevated, although it was tough to interpret in the setting of kind of concern for overarching inflammation. Her ANA was low. Her anti-smooth muscle was low. Her IgG was low. She had normal ceruloplasmin and normal copper. Her hemochromatosis panel was pending. And we talked about her ischemic or her congestive hepatopathy workup, which is negative. She had an ultrasound with Doppler that didn't show any evidence of clot in the liver vasculature. The MRI was overread by our radiologists, which pretty much had the same read. She just had some mild wall thickening and edema of the visualized bowel loops, but nothing specific otherwise around the pancreas, in the liver, no evidence of bile duct dilatation, no evidence of stones. all of her other organs on her MR abdomen were unremarkable. So to kind of summarize, she's improved her LFTs are starting to downtrend. They're kind of in the 800s now. She's, her electrolytes have normalized in the setting of being on dialysis. She is much less volume overloaded. She has now been transitioned to a sub-Q insulin regimen and has been doing okay from that standpoint. Her gap is starting to close now. And I think at this point, with a mostly negative kind of obscure workup, minus a couple of tests that are pending, how are you putting all of her organ dysfunction together?
Luckily, Kara, it's Robbie's turn to talk.
Oh, Prof. Rez, how I'm putting it together, I have an easy answer for you. That's that's really it. I mean, at the end of the day, I think that it's actually really, really important to watch what happens over time, because I think that you are able to rein in this process, and I think it's very hard to rein in a multifocal infection or a progressive malignancy, and so I think that this process, by being able to wrap your hands around it and contain it and push it back in, it makes it interesting to see what you're left with. And I think you're either left with a spontaneously resolving process, such as that unleashed by an unrecognized toxin, or you're left with the fact that actually something that you treated her with is making her better. And so I think the focus of your specific treatment has been, you've given a lot of supportive care, right? You've given fluids, you've given renal replacement therapy. The most specific thing you gave her was insulin. And so I don't know how I would be putting it together, but I'm just so struck by how insulin resistant she was, and whether that degree of her insulin resistance, despite her BMI of only 28, is the arc by which you would get an answer, and whether or not she has some insulin antibody, or whether she was hypertriglyceridemic this whole time. But yeah, I would be following the pathway of, oh, maybe this was a toxin that we'll never really find out. Or maybe the pathway should be, this was a chaos unleashed by insulin deficiency or relative insulin deficiency. And she either had really bad triglycerides, or she had really bad, really rare, unusual insulin resistance syndromes. But yeah, I don't know if I can make any more progress than those fleeting thoughts. Prof. Rez?
Zero to add. Dude, I'm realizing my lines are like those corny sitcoms where someone fans to the grandma who says the one word comment, and then the audience starts laughing, like, eat my cookies, and everyone's like, ah, and then the person shuts up for the rest of the episode.
I guess, Kara, what are your thoughts? How are you putting this patient together?
Yeah, a couple of things. So we'll go by problem. For her acute liver injury, at the time, after giving her some time and she had improvement with dialysis, and there was we were trying to tie all this together. We thought maybe what had happened was she had ischemic hepatitis and multi-organ failure, including very bad pre-renal injury that had turned into ATN in the setting of volume depletion from her DKA. As one possibility, there were two main things that we were entertaining, because her A1C was so high and it was really unclear, just as Reza had mentioned, how truly adherent to her insulin she was. And if her poor PO intake had more spanned the course of 2 weeks rather than the 2 days that she had initially brought, because, sorry, I didn't mention this, but she was brought in by ambulance, Rabih. She did not walk into the triage room. The second thought, which has been I've seen entertained in the chat, was given that her lipase was far above the upper limit of normal, it was possible that her primary problem was pancreatitis, maybe some autonomic neuropathy or something that was like making it so that she couldn't really have, like she didn't really have abdominal pain. Although it was difficult because there wasn't a ton of inflammation obvious on the MRI from like multiple radiologic reads, that could have had a high lipase, and then that triggered an episode of DKA, and then that all compounded with hypovolemia, resulting in her kind of multi-organ failure. And because the rest of her like liver workup was negative, of note, she did have her hemochromatosis panel came back for H6 3D heterozygosity, and so but she didn't have an additional mutation that would make it seem obvious that she would have iron overload from like a hemochromatosis like picture. And so there was more, it was ultimately either that she was like extremely hypovolemic from the DKA resulting in multi-organ like ischemic injury, or that she had pancreatitis that triggered DKA and then resulted in multi-organ injury. From her AKI standpoint, I think what really would have been helpful to have Reza there, because you take so much of the acid base like initial interpretation at face value, and you don't necessarily do all of the initial calculations, but she had like compounded acid base disturbances. And the thought was that we had focused so much on the DKA that we kept her on the insulin drip, and we were really nervous about transitioning her to sub-Q insulin. And it turns out that wasn't the major contributing factor, because there was a non-GAP acidosis on top of the GAP acidosis, plus a respiratory acidosis. And so the thought was that because there was no ingestion, comp tox was negative, she denied up and down that she used any substances or had any ingestions. The thought was that she had AKI, thought to be prerenal hypovolemia that had progressed to ATN and then caused like had a uremic cause of a metabolic acidosis on top of that. And she was able to come off of dialysis after a couple of sessions because she had renal recovery. As for her diabetes, they sent zinc transporter, GAD65, islet cell, IC1512, all were negative. And she had a little bit of a low C peptide, but based on endocrine's interpretation of that, they actually didn't think that this was consistent with a picture of type 1 diabetes, and that she was more in a type 2 picture with that was ketosis prone, given the like significant amount of insulin resistance that she was demonstrating. And so overarchingly, kind of all ties back to like hypovolemia in the setting of DKA as like a potential root cause. And I think that overall, the reason why I brought this case was that like you had entertained all sorts of like infiltrative causes, all sorts of like rare causes that like could potentially be explained by just like very bread and butter medicine. And so that's the conclusion. I'm sorry if it wasn't like a rare lymphoma, Rabih.
Oh, so Kara, I just want to say, like, I love like the CP solvers community, because just if you go back and listen to your conclusion, it's just like medicine at its peak, like the curiosity, the way that you're just like dropping terms as if you were each of the subspecialists. And I know that is in large part because of who you are, but also because of the community that you guys have all created. So I love that hypothesis. I'm really happy this patient is doing better. But for me, like, I don't think I've ever been this overwhelmed by a case, honestly, because it was a lot of data, but every data point was significant. And maybe at the end of the day, like, Robbie, you know how you have that schema for full body pain, like what goes through the entire body? What goes to every organ is pressure, is blood. And so when all these organs are down, that's like a really good initial if you're going to do base rate. Anyways, I'm just really impressed by you and like your understanding of medicine. And thank you for this case where we got to talk about so much bread and butter. Yeah. And Mike, to you, Robbie.
Yeah, Prof. I'm bloated on bread and butter, which is something so nice to be full on, honestly. As I sit here sipping matcha tea, the irony of that. But it was so much fun to dissect this case, and I think that Yeah, the amount that we got to talk about bread and butter was awesome. And the fact that the conclusion is actually like real life is just the cherry on top. And I think for me, the lesson I learned was asking myself with the question that Prof. Rez was asking out loud, which is how are we going to figure this out? And I think all too often my mind expects a test to clinch the answer. But I think here, the fact that you offered no specific treatment to the patient apart from no targeted treatment apart from insulin allows you to come to a very clear conclusion. Either this was a spontaneously resolving process from a transient insult, like a toxin, you never know, or that this was an insulin responsive disease state. There's nothing else that you gave that was disease specific. And so it's just a humbling lesson to see how insulin resistant somebody can get. And I think a very open question as to why some people get so insulin resistant to the point where you can't close their gap with insulin drip. It's crazy. And so I'm sure 40, 50 years from now, we can look back on this case and realize actually that there was a little bit of an avocado toast in it that we don't quite appreciate about why somebody went to this extreme of insulin resistance. And I hope we are all alive and drinking our matcha tea that day to like reflect on these cases, because I think there's a little something there. But anyway, final reflections to you, Kara, before we hand the mic to Anmol for teaching points. Any final things you want to emphasize before we learn from Anmol?
No, I want to learn from Anmol.
Thank you so much for the great case. I learned a lot. There were multiple teaching points, and I'll just try to rush through them. So firstly, the patient came with intractable nausea and vomiting. Then we realized that we need to track how in the triage room, how the symptoms of the patient presented. Were they able to move or not? What were the vital signs of the patient so that we can triage the patient into ICU and everything. Then we considered the chief complaint of nausea and vomiting, and considered the differential. So we thought that it could be due to triggering of vagus nerve in a location. Then we thought of two things. First, to localize the nausea or vomiting, which we thought about the three organs: brain, heart, and upper GI tract. So doing a nervous system examination and getting an ECG would be helpful. And if we are not able to localize the nausea and vomiting, then we can consider if it is if it's on a molecular level, if it's a deficiency of a substance or an excess of substance. Deficiency of substance could be due to adrenal insufficiency, and excess of substance could be due to beta-HCG or cannabinoid hyperemesis syndrome. So a drug history or a pregnancy history would be important. Then we realized that the patient had, on the initial labs, the patient had low pH. So we thought about acidosis, and Prof. Rez taught us that there is anion gap metabolic acidosis in this patient, which could be due to four main causes, that is renal insufficiency, ketones, lactate, toxins, or medications. Presence of ketones in urine in this patient and uncontrolled diabetes mellitus made us think of DKA. And now we start thinking about what triggered DKA in this patient. And how do we treat DKA? We treat it with fluids, potassium, and insulin. Then we realized that this patient does not only have an iron gap metabolic acidosis, but has triple acidosis. An iron gap metabolic acidosis with the evidence of ketones, and non-anion gap metabolic acidosis as well, then respiratory acidosis as well. Then this patient also had elevated alkaline phosphatase. In this case, it signals bile duct injury. Whenever we consider a bile duct injury, we have to figure out if it is intrahepatic bile duct injury or extrahepatic bile duct injury, which we can figure out with the help of imaging. But a pretest probability can be guessed from the transaminases and lipase levels. If transaminases are elevated, then most likely the intrahepatic bile ducts are injured. And if the lipase levels are elevated, then the extrahepatic bile ducts are injured. But they can be falsely elevated as well. So we need to keep that in mind. And then we realized that the lipase level was very much elevated. So we thought about the main causes of acute pancreatitis, which we need to consider: alcohol, which was not present in this patient; gallstones, which was a strong possibility, and third was hypertriglyceridemia. Regarding gallstones, we thought that it is the only extrahepatic disease that can cause elevated transaminases. So in this patient, it kind of it fit well. And why the transaminases are elevated in the extrahepatic? Because of the backward mechanical pressure of the gallstones. And we saw that this patient had elevated transaminases in the level of 1,000, which showed that was a severe acute liver injury. So what could be the main causes for that? Ischemic liver disease. And patient does not need to be hypotensive to be ischemic liver disease. The patient could have a thrombosis of portal vein. Second cause was hepatitis virus and herpes virus. Third was toxins, Tylenol, and fourth was stones, as we discussed. And then and we said that in severe acute liver injury, we need to figure out if the patient is having acute liver failure, because otherwise then we need to treat that. And which we can find that out from encephalopathy or hysterexis. And we have to, if the patient is not into failure, we have to monitor if the patient does not go into failure. So these are the things to be kept in mind. And then the patient had ascites as well. We thought of the importance of an ascitic tap, especially to look for SBP and portal hypertension. We discussed that portal hypertension mostly comes as a result of chronic fibrotic liver disease. So presence of ascites with no apparent cause other than portal hypertension in this patient makes us think if the patient had a chronic liver disease, because this picture seems to be acute because of the severe elevated transaminases. Then we think of any chronic liver disease, we think about many differentials like acute decompensated right heart failure, Budd-Chiari syndrome, and the basic test which we need to send, BNP, TSH, free T4. And then upon the further workup, we realized the heart tests were normal, so which ruled out post-hepatic causes of portal hypertension. Then we start thinking about the intrahepatic or pre-hepatic causes. Then we think about if there is a lesion infiltrating the liver, which is occupying the space, causing all these symptoms. Then we saw that the anion gap persisted even after the treatment of DKA, even post-fluids. So we thought that maybe DKA was not the main cause causing maybe there was another contributing factor to it along with DKA. So we thought about if renal insufficiency or uremia is also contributing to metabolic acidosis. Ultimately, we realized that it was a very complex real-life case, which had so much pathophysiology to understand, and it was DKA and a multi-organ failure and hypertension contributing to all of the symptoms. And thank you so much for teaching it. I learned a lot. Thank you so much.
Oh my gosh, Anmol, you should be like a professional opera singer, because if you can complete all this in basically one breath, you're able to reach the peak notes of music. That was unbelievable. I think that's the most amount of teaching points jam-packed into an hour-long session ever. So really, really amazing job. And for all of you, you should know that Anmol's been under the weather and somehow made the mistake to decide to do teaching points today, which she is not regretting because she crushed it. That was amazing. Kara, thank you. I will see you in 3 seconds. Prof, that was awesome, man. Thank you so much for hanging out. That was a real treat. Bye, guys.